So topic for today, we're talking about GLP-1 agonists in substance use disorder. Um, and we'll focus mostly on alcohol because that's where there's been the most research, especially with the earlier rodent studies, but we'll talk about some other studies that have recently come out as well. And yeah, I'm Tayler, one of the fellows. No financial disclosures for this session. So some of the objectives, we'll talk about GLP-1s, we'll talk about their mechanism of action, and specifically how they are working for substance use disorders. We'll talk about some of the leading human studies on GLP-1s. Like I said, mostly talking about alcohol use disorder, but there's an article that was just published on opiate use disorder. And then last month, an article was published as a systematic review as well that we'll go through. We're going to talk about some of the pros and the cons, and because this is such a costly medication, some of the cost impacts and potential future medical disabilities. And huge thanks to Dr. Moeller. So she was a fellow from last year that initially presented this part of this presentation, at least, for ASAM last year, and kind of have just updated it with the more recent studies that have come out throughout the summer. So why are we talking about GLP-1s? Because everyone else is talking about them and we're getting questions about them. Other physicians, from our patients, from our family members. So we should just be aware of what this class of medication can and cannot do and some of the risks and benefits associated with them. And specifically in the field of addiction medicine, there's a lot more articles coming out that these drugs could potentially have a use for treating substance use disorder. One of the articles was one of the most read articles from last year in the Journal of Addiction Medicine. So lots of people are talking about it. We should be too. Because these drugs are so popular in the last few years, there have been a lot of shortages. And with shortages, a lot of these new compounding companies have come out. So another thing that we should just be able to educate our patients on, because there are a lot of risks with some of these compounding pharmacies. They are not subject to the same FDA oversight that normal pharmacies are. So I don't think a lot of people realize that, and there have been pretty serious patient harms because of that. So the FDA doesn't regulate it at all, and it's only regulated by the state pharmacy board, which, as you can imagine, can vary quite a bit state to state on how much they're actually kind of regulating and doing quality control. A little bit of history. So we first started studying kind of these different hormones in the mid to late 20th century, mostly in rodent models. Found out about GLP-1, GIP, DDP4, all of those hormones. And then in 2005, the first GLP-1 receptor agonist was approved for the use of type 2 diabetes. So I think that's just kind of important, because when we think about this class of medications, a lot of us think about the last few years, the year of Ozempic and whatnot. And it's good to know that actually, at least for type 2 diabetes, these medications have been around for almost 20 years at this point. So what are we talking about? We are talking about a whole slew of medications. I'm sure you've heard a lot of these brand names with advertising in the media. Important to know that some of the same drug compounds, so like semaglutide, can be called something different when it's approved for weight loss versus type 2 diabetes, and the dosing can be different as well. So here are some of the big brands. They've kind of slowly come out with more and more products throughout the last 10 to 15 years. Dosing will range. So some of these are multi-day injections, some of them are weekly injections, and then the semaglutide approved for type 2 diabetes down there is the only oral option at this point. Semaglutide is more efficacious for weight loss and for diabetic control, but now we're seeing that there's even better drugs in the dual and triple agonist category. So that's this tirzepatide, that's a GIP and GLP-1 agonist. And then the triple agonist is currently under FDA review, I think still, but more to come. So what is GLP-1? GLP-1 is endogenously a hormone that's released in our intestine by endocrine L cells. The problem with our kind of intrinsic hormone is that it's rapidly broken down. So this DDP4 enzyme breaks it down in a matter of minutes. So obviously that would create a lot of issues for a commercially available pharmaceutical product. So what all of these pharmaceutical companies have done is just kind of modify it a little bit so it's not broken down in the body. And now that's why the dosing is different, because different GLP-1s within the class are going to have different lives. So where is it acting? Ton of different sites in the body that we know about so far, and a lot is still being studied. So most of the data we have is regarding metabolic disease. It increases insulin production. It decreases glucagon. It slows our gastric emptying, so it has impacts on satiety. It changes our homeostatic and hedonic feeding, causing us to eat less, has reduced cardiovascular risk, even with patients without type 2 diabetes. And the reason we care about it for substance use disorder is that it modulates the dopamine reward pathway. Yeah, and so obviously that's important for substance use disorder. Diving into that a little bit further. So here's kind of a visual representation of where we see these receptors in the brain. Highest concentration is going to be in the nucleus tractus solitarius, with projections to those dopamine areas, the ventral tegmental area, the nucleus accumbens. And that is just kind of the best studied pathway right now, but we think that there's probably other factors contributing to why this drug is helpful for substance use disorder. There's been thought that it might change the GABA pathway a little bit and kind of act on the more negative affect withdrawal phase of addiction. And then they have seen in the mice and rodent studies that some of the drug conditioned behaviors is affected as well. So looking more at kind of the classic drug studies with conditioned place preference and the operant behaviors. So pressing a lever to like self-administer alcohol, for example, is reduced. So getting a little bit more at like the craving phase of addiction. And do they cross the blood-brain barrier? Has been studied somewhat for Parkinson's patients, and the answer simply is yes, but the different GLP-1s cross with different ability. So basically not all GLP-1s are treated the same, and so we have to study them all individually because they could have slightly different effect. So talking about the animal studies a little bit, this is where the research at least started before we had more of the human trials. So back in 2013, they first saw the association with exenatide. So that's the EX4. That was the first GLP-1 that was FDA approved. They saw that at least in male mice, there was a reduction in alcohol intake. And then they kind of replicated that studies with other GLP-1s, saw similar effects. Interesting because it was only seen in the male rodents, so there was a sex effect in some of these early studies. And they did comment that some of these early studies were more like alcohol habituated mice, but didn't quite mimic the same ethanol levels that we see in humans with alcohol use disorder. This last study that I have on there, the 2022 study, did try to replicate that a little bit better. So by changing like the sleep-wake cycles of the mice, you can actually get them to drink a little bit more in a binge-like fashion. And this study was looking at semaglutide, so important because we see that, like I said earlier, semaglutide has better efficacy for glucose lowering effects, weight loss, and it's the only oral option that we have available right now, so it might be a little bit more easy to administer in this population. This study did not see the same sex effect. So they saw that the dose-dependent reduction in alcohol intake was seen across the board, so male and female mice. What they did see in this study, though, is that the intake of everything was reduced. So it wasn't just that these mice were drinking less, they were eating less, they were drinking less water, they were drinking less sweet alcohol or not sweet alcohol. So it's kind of across the board. And I think this brings up the important point with GLP-1s and some of the weight loss studies or kind of hypothesis is that are we just seeing with these medications that people are just reducing their intake of everything? Is it just like an anti-consumatory response that is helping people with their substance use disorder? We think partially. So we do see that this happens in mice. They call it visceral malaise. So they're looking at stuff like pica behavior. They're looking at stuff like food avoidance. And we do see that in the mice. They experience that. So that would be like equated to nausea in humans. And someone's singing in the hallway, sorry. We don't see that same effect in monkeys, so that's interesting. And then if you were to kind of hypothesize that that was the only mechanism leading to weight loss and some of this reduction in use, you'd kind of think that semaglutide in comparison with the other GLP-1s would have higher rates of nausea if that's really the only thing that's contributing to this effect, which we don't see in at least the metabolic studies. Semaglutide has the same rate of side effects as the other GLP-1s. And the other reason we just like shouldn't, the other thing that we've done is when we inject these products, so the exenatide directly into some of these brain areas, you don't see the same visceral malaise. So it's probably in part some of the mechanism, but not the whole mechanism. And even if that is part of the mechanism, we shouldn't necessarily discount this as a medication for alcohol use disorder in general. We know that a lot of patients with alcohol use disorder have comorbid metabolic disease, something like 1 in 5. And if you compare it to topiramate, so a second-line medication for alcohol use disorder that is also a weight loss drug, there's just still room for other drugs to be utilized in this capacity. All right, so going on to the human studies. This is probably the best study we have so far on alcohol use disorder. It's a randomized controlled trial. It was done out of Denmark. Everyone had a diagnosis of alcohol use disorder and was seeking treatment. So that was our patient population. The N of this study was 127. Some of the main inclusion criteria was heavy drinking days. So these patients all had to have at least 5 heavy drinking days in the last month, which was defined as like standard binge drinking day. And exclusionary criteria, you couldn't have episodes of pancreatitis, so important for patients with alcohol use disorder. And otherwise, they kind of looked at the standard GLP-1 exclusionary criteria for contraindications. And then they did a subset analysis, which was kind of interesting on some of the patients and did functional MRI scans and SPECT CT scans on them. Oh, and one of the other contraindications for this study was that they couldn't be on any other medication for alcohol use disorder. So nobody was on disulfiram, acamprosate, naltrexone, or nalmefene, which they use in Europe. And so these
Did they say about how many, did any of the patients have diabetes or type, elevated hemoglobins, A1C or anything?
They actually excluded history of diabetes, but they didn't comment on obesity or pre-diabetes.
Okay, thanks.
Yeah, important note. And actually, they didn't exclude based on obesity because I'll show you kind of some of the results in the next slide. But this was the final endpoint for the two different groups. So placebo, exenatide, no difference in their drinking pattern, the amount they consumed, or the number of heavy drinking days. And they did look at labs. They looked at PEth at the beginning and end of the study. They looked at liver enzymes. They looked at lipase levels. So it was a pretty well done, comprehensive study. What was interesting is they did actually see a difference between the brain scans in these two groups, but it didn't correlate with a reduction in drinking. So in the exenatide group, there was decreased Q reactivity, there was decreased dopamine transmission. So kind of interesting, but not quite sure why that didn't translate over to a change in behavior. What they decided to do with this study is do a subgroup analysis, which I think is why this paper has gotten a lot of attention, because they saw this very interesting effect. So if you look at the different BMI groups in this graph, we have high BMI, BMI greater than 30, and then normal BMI less than 25. And there was a completely flipped response. So in the low BMI group, there was actually over 20% increase in the number of heavy drinking days throughout the course of a month period. And in the high BMI group, there was a similar reduction in the number of drinking days and the amount actually consumed. They did try to do like a subgroup analysis of the brain scans here too, but they said it wasn't powered high enough just because this was like a much lower end of their total study. So very interesting, suggesting that there's possibly some different mechanisms at play and that this wouldn't be a kind of one size fits all type of medication, but it might be tailored to specific populations. Lots of side effects reported in this study. So the GI side effects were very high in both the exenatide and the placebo group. So they did comment on that compared to other GLP-1 studies. The placebo group had much higher rates of nausea, vomiting, and even weight loss. There was no episodes of pancreatitis. There was some serious adverse effects in both groups. So one group, the exenatide group, had a patient complete suicide, but that was 7 months after they were taken out of the study. And then in the control group, a patient died from complications of alcohol withdrawal. They commented that he had been hospitalized 3 times in 1 week. And because of a combination of things, including some of these side effects, the dropout rate was 54%. So a very high dropout rate, much higher than what is seen with the other GLP-1 studies. Not crazy compared to other studies with substance use disorder, but something notable for sure. What was interesting in the discussion of this article too is they commented on the fact that even though they considered this patient population to be heavy drinkers, if you look at the amount that they were reporting to consume, it was actually much lower than some of the other studies done on medications for alcohol use disorder. So maybe the severity wasn't high enough to capture some of the response that they were expecting. And they also said that because they had a lower severity of alcohol use disorder, that maybe the placebo group was augmented because everyone in the study got CBT. So I think just some things to consider. Moving on to opiate use disorder. So this study was just published in September. A different design of the study. So this was not a randomized controlled trial. This was a cohort study that pulled data from the US in much more of like a population health kind of manner. Everyone in this study had type 2 diabetes and opiate use disorder, and they looked at patients who were prescribed semaglutide versus any other anti-diabetic medication. So they looked at insulin, they looked at other GLP-1s. The N was 33,000, so a pretty high number of patients in this study. And of that, 3,000 patients were prescribed semaglutide. Some of the patient demographics to consider or characteristics. These patients were allowed to be on MAT. Looks like only about 30% in each group were on methadone, buprenorphine, or naltrexone, and there was kind of varying rates of what medication depending on what group they were in. Because this was a cohort study, the groups didn't perfectly match, but they did some fancy statistics. They called it propensity score matching to try to get the groups to be as similar as possible for them to do their final analysis. And they did see a pretty marked response in the GLP-1 group compared to every other medication that they studied, and that included other GLP-1s as well. So the semaglutide versus other GLP-1s, semaglutide versus insulin, semaglutide versus other anti-diabetic medication. The hazard ratio for the endpoint of opioid overdose was 0.3 to 0.58. So quite a big difference there. I didn't include another study, but just for people to be aware of, they did this same exact study for alcohol use disorder. The same group did with the same kind of data set, and they looked at people with alcohol use disorder, with co-occurring obesity or type 2 diabetes, and also saw about a half reduction of incident or recurrence of alcohol use disorder in that study. So something to know about as well.
So just a question there. There were these were patients who were already on the drugs, right? They were on them for diabetes, and
Yep.
then they happened to also have opiate use disorder.
Correct.
Or
Yep.
they gathered those that. So why did they hypothesize at all why semaglutide would be different than the other GLP-1s, or what I mean, how do you explain that? Because there's not really a different mechanism, right?
Yeah, and they didn't. I think it goes back to some of the earlier animal studies and the questions that were posed in those trials of like, all these GLP-1s do have different effects, and why are some different than others? I don't think we quite know yet. We know
Okay.
that impacts like our glucose and our weight loss better than other GLP-1s as well. So I think there's just a focus on studying semaglutide with human trials now, because it's thought to be that, at least with metabolic endpoints, that it's more efficacious.
And what about opiate use disorder? I mean, what about their opiate use? Anything on that? Did they report anything about reduced, amount or reduced use of opioids?
I didn't see that they really looked at that, and I don't think they could, because they were just looking at this large data set. So they really just looked at opiate overdose as far as
Okay.
that. Yeah. So
All right, thanks.
that's a great point, though. There's a lot of gaps in kind of the information there.
And you said there was a difference in like somewhat in terms of the medications they were on for opioid use disorder. Did they try to control for that in the propensity score matching? Do we know?
They
Or
did.
They did.
They tried to control for every characteristic that they listed in their table. They had about 20 different variables that they were using, mostly demographic information, but
Okay, so they did try to control. One group had more buprenorphine access than the other.
yep.
Okay.
So
Okay,
I believe so.
gotcha.
They didn't go into a ton of detail on how the statistics were done. It was actually
Yeah.
a pretty short article.
It was, yeah.
So,
As
some
far
of
as
the
we know,
stat
they
stuff
tried.
is over
Yeah.
in my head too.
No,
but-
fair. And that was my read on it too. I was just trying to see if you found more, just because I just wondered a little bit in terms of access.
Sure.
Access to buprenorphine, right? Those vary amongst different populations.
Yeah.
And would that affect outcome too?
Yeah, that's a good point. All right, moving on to the systematic review. So, the first systematic review we have, or specifically GLP-1 agonists and substance use disorder. Once again, like hot off the press, this just came out last month. So, we'll be hearing a lot more about this, and as more studies come out in the coming few years, but this looked at all of the human studies that were peer reviewed. So basically the only thing they excluded were case reports and case series The last study we talked about, for example, was not included
Code
because it just
21,
came out
South
too
Building, Pediatric
recently, so it
Emergency
wasn't
Department,
included when
Floor
they did
2,
their
Fast Track
data poll.
1, hallway. Code 21, South Building, Pediatric Emergency Department, Floor 2, Fast Track 1, hallway. Code 21, South Building, Pediatric Emergency Department, Floor 2, Fast Track 1, hallway.
All right, so they found 5 different studies that met their criteria, 2 on tobacco, 2 on alcohol, and 1 on cocaine. The tobacco study had mixed results. So
Code
one
21,
study found
South Building, Pediatric Emergency Department, Floor 2, Fast Track 1, hallway. Code 21, South Building, Pediatric Emergency Department, Floor 2, Fast Track 1, hallway. Code 21, South Building, Pediatric Emergency Department, Floor 2, Fast Track 1, hallway.
Boy, it'd be easy to get confused on where to go on that code. That's a long announcement. Anyway,
they
sorry.
those this morning, but
And there's almost always a cancel code 21.
yeah. All right, so we needed that break to digest all of this anyway. 2 articles on tobacco use, 2 articles on alcohol, and then 1 on cocaine. The tobacco studies were mixed, so 1 found a benefit, 1 found no benefit. They were both randomized controlled trials. The one that did find benefit was a study out of Houston, with co-occurring metabolic disease. So they either had obesity or prediabetes. The first study on alcohol use disorder is the one we already talked about, that first RCT that I reviewed. And then the second study is another study from Denmark. This one was more similar to kind of the papers I just talked about. It was population level data. I think I have a, yeah. So large N, 87,000. Did not need a prior diagnosis of alcohol use disorder in order to be included. What they looked at is from the prescription registry database throughout the whole country. Anyone that was prescribed a GLP-1 or a DDP-4 throughout like the course of several years. And then they looked at alcohol related events. So they classified things like being enrolled in alcohol use disorder treatment in the National Registry. They said if you were prescribed a medication for alcohol use disorder, including chlorodiazepam epoxide, and then if you had like contact with the healthcare system with a primary diagnosis of alcohol use disorder, so hospitalizations, ER visits, that's kind of the events that they classified as kind of triggering an endpoint. What they saw is a pretty significant decrease in these alcohol related events in the GLP-1 group versus the DDP-4 group, which once again is interesting if you're thinking of mechanism of action, because if you remember from earlier on in the talk, the DDP-4 inhibitors, well, the DDP-4 is the enzyme that breaks down GLP-1. So if you inhibit that, you have more GLP-1 available, but that would be our endogenous GLP-1. So they should have similar endpoints, and they don't necessarily. So just kind of something.
Yeah, we don't really use DPP4s
Yeah,
inhibitors anymore in general,
Yeah.
right? Because they just aren't as effective.
I don't think I've ever prescribed one
Yeah,
in
I know.
residency. So, but kind of interesting. And that's why I think they chose to study those 2 medications. They're also were kind of novel agents during the time period that they looked at this pharmaceutical registry. So interesting results there. The one caveat to this study is when they did a self-controlled analysis, so they looked just at the GLP-1 group, they had kind of mixed results. So compared to the GLP-1s, like incidence of these events before starting the medication and after, they saw an initial decrease. So the first 3 months, there was a decrease in those alcohol-related events. But then there was actually an increase from baseline from like 4 to 12 months, and then they went back to baseline. And basically the discussion commented on it, but didn't really go into hypotheses other than to say, we're not sure why this happened. Are we just seeing that because this is a cohort study that the difference in kind of treatment groups or the difference in the two cohorts was significant enough to like see this result, but it's not a true result. I think we just need more RCTs to be able to flesh that out a little bit more.
The 2022 one, that was the semaglutide, the Clausen?
That was, yeah.
It was semaglutide.
Yep.
What are the alcohol related events they're talking about here? Is it like hospitalizations or, deaths or what?
Yeah, that was the 3 kind of criteria that I said: the contact with the healthcare system with a primary diagnosis of alcohol use disorder, being prescribed a medication for alcohol use disorder. So they looked at kind of the classic medications and then chlorodiazepoxide. And then the third criteria was being registered in the National Denmark Registry for treatment for alcohol use disorder. So going to the hospital, disorder, going into treatment with alcohol use disorder, and being put on a medication for alcohol use disorder were the 3 main categories.
Okay.
Yeah. And presumably all of these patients had a metabolic indication to be put on one of these medications. The third category there is the cocaine study. This was an interesting study, totally different than the rest of the studies. It was a very small dose of exenatide, so it was on the microgram level when we use milligrams for true treatment of like type 2 diabetes and weight loss. They did a one-time infusion and then looked at cocaine self-administration while patients were hospitalized. The N was very small, it was an N of 13. And they didn't see a difference in that group, but it was kind of a weird, funky study. Conclusions from the systematic review. I think we probably all gathered this by this point, but it's premature to prescribe this medication off-label to patients with the primary diagnosis of substance use disorder. So that would be inappropriate at this point. We just need to gather more information, and there's a lot of unknown questions still out there regarding GLP-1s. The one thing that was interesting in looking at all these studies and putting it together is all of the studies where there was seen to be a benefit with the GLP-1 involved the patients with pre-existing metabolic disease. So it really kind of points to what we talked about a little bit ago, that maybe there's a subset of people with substance use disorder that have co-occurring metabolic disease that these medications would be best for. So some of the downsides we've talked about already. Drug shortages are something very real that face patients right now. There's the risk with compounding. There's a very significant cost of these medications right now in the US. People are needing prior auths. Some insurances will only cover certain GLP-1s, and you need to change up your GLP-1 treatment. What is really something to consider is how this could lead to further healthcare disparities within our substance use disorder population. Thinking back to, for example, comparing it with Hep C treatment, something that's $90,000 per month, the uptake was very low. And are we just gonna worsen medical disparities within this subgroup of people? Other downsides are side effects. So as we kind of pointed to with the Clausen et al. Study, our patients with alcohol use disorder are kind of more prone to GI side effects. And so if you add on a GLP-1, how long will they be able to tolerate it? We're not quite sure because of side effects, insurance issues, kind of availability issues with the drug. A lot of patients aren't staying on these medications long term. And right now there's quite a few different contraindications. So pregnancy, type 1 diabetes, medullary thyroid cancer. Important for us is history of pancreatitis. So especially with alcohol use disorder, that would be an important consideration. We talked about a little bit the overlap between alcohol use disorder and metabolic disease, but a fair number of our patients are kind of on the other extreme and are low weight, and really wouldn't tolerate a significant weight loss if they were to be started on this medication. So things to consider. Upsides, renally cleared, so good for alcohol use disorder if patients have hepatic issues. The idea of drug repurposing is very promising. Not having to kind of create a new drug and manufacture it from scratch, but rather just using something already on the market and something that a lot of PCPs are already prescribing for other patients is pretty exciting. The thought is too that there might be less kind of stigma associated with these medications since they are kind of just publicized in the mass media so much. Everyone knows them as weight loss medications, and they might not have that tie to addiction, which could be beneficial. And we know we need more options. So they looked at a study a few years ago that said patients in the US with alcohol use disorder, only about 2% of those patients are prescribed a medication. So we know as clinicians, we need more options for these patients. Unknowns, there's a lot of them. So we don't know the proper dosing. We don't know which GLP-1 is going to be better. Are these dual and triple agonists going to be even better than semaglutide? What's going to be like the perfect patient population? How long do patients need to stay on this medication? There's just a lot of unknowns. And there's still kind of hypotheses regarding the true mechanism of action. So we need to clarify that as well. That's all I got. We can go back to things, or we can discuss whatever people want.
So feel free to unmute and ask questions if anyone has any.
I have two doubts that I have. The first one, given the treatment is that broad, let's say cocaine, tobacco, or like, do you know like what type of receptors? I understand it's kind of like a glucagon-like protein, but do we know so far what type of mechanism or what type of receptor that allow to prevent it as broad? Like you have different type of substance. I don't know if you see what I mean. If they have look at which receptor, which mechanism. The other thing that I also have is what's the long term? Let's say somebody's on naltrexone for a long term. There are things we can anticipate those patients will have. But what could be some long term? I don't know. I don't know if we have study over 5 or 10 years with somebody being over a long term, or if it is kind of like a treatment for I don't know 1 year or 2 years, and then after that you stop it.
Yeah, I think that's what we don't know still. So we've had patients on type 2 diabetes that have been on this medication for around 20 years now. So we have a little bit more longitudinal data regarding like long-term effects, which as far as I'm aware of, there's not a lot. We know, well, we historically thought that it increases your rate of pancreatitis, which that's kind of being questioned now, but I don't know if you've seen other more
Thyroid,
significant-
there is a slight
Yeah.
signal that just beyond having that family history of like MEN2A, there might be a slight signal, an increase in thyroid nodules and maybe thyroid cancers. Yeah, that's still in debate. That's on huge, large scale, data.
Yeah,
But so I think that's still a question, and the question of how long they need to be on this medication, I don't think we know at all. Because would it be the same where, like, would we expect the duration to be the same for if we were prescribing it for weight loss? We don't know. If we prescribe it for 2 months, are we going to see residual decrease in alcohol use 2 years down the line? I don't think we have any studies that kind of support that yet. And getting to your first question, so looking at the different receptors, I don't know if they've looked at which kind of pathways are more implicated with different substances, but they have seen, at least in, I think this was done in the animal studies, that we have different subtypes of GLP-1 receptors that are more likely to be correlated with a substance use disorder. So that's kind of interesting. I don't know that we're like targeting those subtypes, but maybe there's something about like our genetic propensity to developing a substance use disorder that has to do with what type of GLP-1 receptor we have.
Oh, is it like a craving? Because sometimes I have some of my patients crave food and then I put them on metformin, and for some reason it decrease.
Yeah, is there a general consumatory drive that's
Yeah.
different in some patients? That gets back to that subset analysis. There was one group that had the higher kind of BMI that did well, the other group did not. And so is there a difference in what's driving some of these? Who
Yeah.
knows? I mean, we don't know these answers yet.
Yeah.
And I
But
think that's
it's an interesting
interesting
question.
when you
Yeah.
think about like alcohol versus other substances and how you consume things
Mhm.
too. Like,
Yep.
are we seeing more data, robust data for alcohol? Because that's something we ingest versus injectable
Yeah.
kind of substances versus inhaling substances. I don't know.
Yeah, that's an interesting thought too. There was a request in the chat. If you could go back to show the slide that shows the effects of the GLP-1 agonists on the body. I mean, it was up, one of the early slides. Yeah, there. There. Is this the one you wanted, Dr. Middlefort?
Yes, thank you.
Okay. Okay.
Great slide. I like that.
Yeah, that's a good slide. It's got, I mean, clearly it has, our GLP-1 receptors are in a lot of different organs and have a lot of different effects. So that is one thing when we're using these, I think we have to consider what else are we affecting? And I mean, what's the role of insulin sensitivity and glucose production and lipolysis and such in alcohol use disorder, for example, so the studies, I think, where they inject it right into the brain are kind of interesting and maybe, I mean, I think as far as your final question, would you use these in clinical practice? I mean, I don't think there's enough data yet. And I think it would really be helpful to do more of the basic science and, animal studies to really try to get a better handle on this before we even consider using it in humans. That's my opinion. I mean, I think there's going to be, as you said, people are kind of clamoring for this, and I think it's partly related, to the weight loss, but I really think we have to be careful about what evidence there really is. And right now, it doesn't seem like this evidence is very, very strong, but that's my opinion. So
I think there are some currently going RCTs on semaglutide. I think Cube is involved in one. I've seen a couple they're doing research right now.
Yeah.
So hopefully we'll have some
Yeah.
done within a number of years.
That's systematic
Yeah.
review whole list,
These
and
are
there's
bunch.
9
Yeah.
current, I think randomized controlled trials on this, and half of them are analyzing data right now. So in the next few years, we're going to see tons
I'm
of
sure. Yeah, I'm sure it's a hot area.
And I almost think that like the only clinical application at this point is like a hypothetical patient that is refractory to all of our standard alcohol use disorder medications, who has a metabolic indication to be on the medication, where you might partner with their PCP to urge them to consider this over some other anti-diabetic, kind of crossing our fingers and hoping that it has some effect. But I think that would be a stretch.
Mhm. I also think you had something in there in one of the discussions about only 2% of patients are actually receiving any medication for alcohol use disorder.
Yep.
I mean, so, And we have medications that have been shown to have some efficacy. I mean, not 100% by any means, but so the problem is we're not even prescribing the ones we have. I mean, in a very large number. So that's one thing I think we need to emphasize, is that any patient with alcohol use disorder, I think, should be offered one of the medications that we know have some benefits before I would go to this one, to a GLP-1.
Absolutely.
I mean, that's I was really surprised at that low number.
Yeah, I think that study was from 2001, I want to say.
Mm-hmm. So, but it is interesting I mean, there, like you said, there could be individuals, particularly certain, with certain issues, that could benefit.
Yep.
I don't know. We just don't know yet.
Yeah.
Any other questions, comments, thoughts?
Thank you.
Yeah, thank you for joining.
Well, there's
Yeah.
so much discussion about these. It's nice to have a data review. So thank you, Taylor.
Yeah.
Thank you, thank you.
Yeah. Thanks a lot. You go by Taylor rather than Robert, huh?
Yeah, I do.
Yeah, so
Okay. I'll try to remember that.
And we've got next month is going to be one of our other fellows here, Katie McKay, is going to present on just kind of review of Brixadi and kind of how it's being utilized.
Okay.
Situations, I think, is a worthwhile topical one. I know it's been out there for a little bit, since September of last year.
Uh,
How it's been uptaked, how it's being utilized in different settings. So
yeah, great. We'll look forward to that. Okay. If no other questions or comments, we will end here a little early. Thank you again, Taylor.
Yeah.
Appreciate it.
Bye.
it's a good run.